I'm going to do a little bit of a commercial, and I'll even let the two of you jump in. Everybody should go to their conference. Just like Vidar just had the experience this last week. Amazing. It really is transformational. And we're going to talk about this later, but the part that for me is so amazing is imagine going to the best healthcare system in the world and spending a week learning about how to do healthcare in a premier way. Imagine all the things you might learn about, the processes, the digital, the computer systems, the way to solve cancer, all these amazing healthcare things, right? Well, you spend 3 days, full days, first 3 days, simply learning from the best in the world how to build trusting relationships. Now, why in the world would you think that an aspirational healthcare model like Nuka would spend 3 days teaching you how to build trusting relationships with people? Give me your thoughts. Why is that so important to the best healthcare system in the world? Patients get better when they trust the provider.
And then the other words that come up when you talk to people, especially people who have been sort of disenfranchised most of their lives, core to their conversation, and again, just to follow April around Juneteenth, and especially Black African-American members of our society, an awful lot of what people say is they want to be seen and they want to be known, and that's a prerequisite for entering into any kind of relationship that's going to have any kind of impact. So I think we're all saying a lot of the same things. I would just add those words to it and strongly follow what April said, which is the core thing is to meet them and follow them on their journey as guests at their table. And this whole professional institutional arrogance has got to go away.
So to your question about trust, I think that healing, we have a lot of healing to do, not just from a physical and emotional and mental health perspective, but we have broken the trust with the American people and our current healthcare system. And so we have to begin healing that broken trust. It's not just starting from building trust from a sort of neutral space. We have a lot of work to do in correcting a broken trust that we've perpetuated.
Somebody said we have harmed trust in healthcare and we have to rebuild. And I just think it's telling that we're having this conversation on Juneteenth, and I just want to acknowledge that distrust in institutions has been a survival mechanism for people, right? It has been the most important thing for your family not to trust what's coming out of the government. It's been successful. I think that Vidar said that you looked at the resiliency and creativity of Native people, and that didn't mean saying yes, sir, to what was coming out of institutions and governments. And we do have a lot of rebuilding to do if we want to really have a meaningful role in the lives of people and families. And the best people to direct us on how to do that are, in fact, those people and families. I'm going to just play a little bit on the comments from the amazing people in the room. I thought they were all really insightful. One of my favorite things about this work we do is that we get to build relationship with people who are thinking differently about healthcare. I heard someone say that patients do better when they trust their providers, and I would turn that around and say healthcare can do better if we trust families and communities to know best what families need. And I heard someone say that patients will be able to comply, right, if we determine what path is going to lead to wellness. And I think in our system we think about that from the opposite perspective too, which is how do we do a good job listening to people and families and using their direction to build a healthcare system that complies with their needs. So really just this play on where power sits, and that trust and relationship is the way that you get to that.
My personal tolerance for words that our staff and other people say is pretty big. And so, we try not to use the word patient anymore. We use customer owner, lots of things in terms of words. But the one that just I don't tolerate is whenever anyone talks about patients being compliant. As April already said, it's the other way around. It's how do we comply with their wants, needs, and wishes and support them on their journey. And to judge people as compliant or non-compliant because they followed or didn't follow what we in our professional and institutional arrogance told them to do is offensive and does harm and is abusive.
it's definitely an honor for me to introduce to you two of my favorite people in the whole world and the Nuka System of Care, created by the South Central Foundation. Recognized around the world, countries from all over the world. Just like Vidar said, last week, countries from all over the world traveled to Alaska to figure out how to do healthcare from the premier healthcare system in the world. They're the only one who have won, the only healthcare system that has won the President's Malcolm Baldrige Award twice. Once in 2011 and again in 2017. You have to wait 6 years between each time you win it. You can't win it every year, right? So what is the Malcolm Baldrige Award? What is it all about? Well, it's all about excellence in performance, continuous quality improvement. Who's familiar with the CQI? I would guess that all of you have heard about, seen about Net Promoter Score, 5 Google stars. Well, Edwards Deming took really nothing more than the scientific method and turned it into simple steps called continuous quality improvement. And those steps are very simple. Who's the customer? Define your customer. What's going to delight your customer? What's going to wow them? What are the processes to be monitored that most impact wowing your customer? And when you find variance in those processes, you get those people closest to the process to improve the process so you can go back to wowing the customer. That is CQI. Deming took it to Ford and General Motors way back. They said, no, we're not interested. So he took it to Japan, and Toyota and Honda embraced those principles and beat up on the American auto industry. Still today, you want to buy a car that's going to last you forever? I own 4, and I just rented one last week and I rented one this week, Toyotas. You buy a Toyota because they last for a long time. That quality that they build into automation still stays there. Now, GM and Ford have tried to catch up, but now, this didn't happen 50 years ago, but now every industry in America adopts and embraces the idea of what's going to delight my customer and measuring to see if we're doing that. You can't do anything. You can't even download an app before, boom, how many stars do we get? It's a part of the way we do life, right? Well, way back when I was running hospitals, first part of my career before I became a reformed recovering hospital administrator, I opened 3 brand new hospitals, ran 10 different hospitals, mostly for the largest HCA, Hospital Corporation of America system. And it was back in the 80s and 90s when CQI was being adopted by our friends, the Joint Commission on the Accreditation of Healthcare Organizations. So here I am helping these hospitals become accredited with a commendation, learning about these CQI principles. And it was very, very difficult not to step back and look at the entire healthcare industry through those lenses and say, oh my gosh, this has got to be the most broken industry in America. Here I sit at the top of the food chain where 40% of all the money is spent, and I literally scheme every day how to work against my customer. What other industry in America can get away with the entire industry working against the customer? Nobody else can get away with that. But here I was. If I just step back and look at, well, I'm not defining my customer. My customer was the doctors, because who admitted to my hospital? It wasn't the one paying for healthcare. It certainly wasn't the employers. Did they want my hospital full? Absolutely not. Everything I was recognized and rewarded for was filling up my hospital. So I left the treatment side 27 years ago and have been passionate ever since about balancing the scales for employers. Well, I really like the theme and the title of this conference, thINc360, because in order to transform healthcare, we truly need to transform and think the opposite. That's what Nuka's done. And there are 4 major things we have to completely transform. Number 1 is the goal. The goal of our current healthcare system is to provide medical treatment, diagnose and treat. That can no longer stay the goal. The goal has to be health and well-being. And that's what the Nuka system has done. They built their entire system on that goal. To the target, we have to go beyond the benefit managers HR and benefit managers will never have the ability to transform this healthcare system. We have to go to the actual buyer. The CEOs, the business leaders of America have to be woken up from this huge blind spot and realize that they're the buyers of the largest industry in America, and they're not holding it accountable. 3, we have to change the way we pay for healthcare. Completely change this whole idea of third-party reimbursement, network contracts. We've got to move to paying cash up front. It's the only way we're going to have significant decreases, take all that middleman out of the road. But tonight we're going to talk about the 4th one, and that is we have to change the front door to healthcare. Why did I buy primary care practices as a hospital administrator? One reason and one reason only. It's a funnel source into the broken system where I can make lots of money. Literally, most every primary care practice in this country on all the networks that we're purchasing for our employees to use are primary care practices that have been purchased up by the healthcare system and held accountable to reach relative value units every day, RVUs. Nothing could be breaking the back of our healthcare, our country than that front door. We have to change the front door. And tonight we're going to talk about the massively powerful primary care system that the best healthcare system in the world has created. And it's my honor to introduce April Kyle, the CEO of South Central Foundation, who created the Nuka System of Care, and Dr. Douglas Eby, the medical director. And I'm going to turn it over to them to share their story. Who's going first?
I will jump in, Daryl. That was a lovely introduction. It's good to see you. You were just up in Alaska a couple of days ago. So hello, glad you made it home safe. Maybe we'll just start with introductions briefly. My name is April Kyle. I am Alaska Native on my father's side from a tribe called Ninelchik, which is about 3.5 hours from where I'm standing today. I'm also Russian, and my mom came here from California. That means I'm a customer owner in our system. I've had my babies in our system, and I speak both from the perspective of a leader in our system and also as a mom and a daughter and an auntie and all the things that customer owner means. I've been here for 20 years. I've been in the CEO role for 3, and before that I was our Vice President of Behavioral Services. Doug, you want to say hello to the group?
Doug Eby, I'm a physician executive. I used to, once upon a time, be a family physician, but I got a master's in public health and administration. Then I became a certified physician executive. I've had tons of training and certifications in quality improvement and complex adaptive systems and all kinds of other stuff. I got really lucky in that I came here 33 years ago, and just over 30 years ago, I was allowed to become the physician partner to the tribal leadership at the time that were in the process of taking over the system from the government. And so this whole system here has been privately owned by Alaska Native corporations and run by Alaska Native people for 25 years. I got to join 30 years ago with the tribal leadership to help scheme the transition and then take the entire system and transform it over time. Just an incredible honor to be allowed to do that. Back to you, April.
Perfect. Daryl, we have a set of slides which we'll move through. I don't know if you can see our faces at the same time. I'm hoping so, but we'll go through these relatively quickly and then leave time for discussion if we can. A little bit of history I think is helpful. What is this Alaska Tribal Healthcare thing? If you understand the history of Native people on our continent and colonization, you know that before Westernization, Alaska Native and Indigenous people had an abundance of land and resources, and they gained the rights as sovereign governments to negotiate with the U.S. government, and those negotiations could include things like treaties. And one of those treaties said that in exchange for the lands and resources lost, that the U.S. government would provide health care and education to Native people in perpetuity. The government's never fully kept that treaty obligation to Native people, but one thing it did is it established a part of the government called the Indian Health Service. I can see all of you in the room. How many people have heard of the Indian Health Service before? Okay, perfect. Everyone, good. Lots and lots of people. So IHS opened up clinics and hospitals, delivered care. That's the healthcare system that I used when I was a kid here in Anchorage. We had an old Native hospital. It was woefully underfunded. It was the second-class place to go. Incredibly hardworking people working in the system because they cared, but a system that wasn't designed at all to even think about population health or keep up with population needs. Along came something called the Indian Self-Determination Act in the 70s, which said, rather than the government delivering healthcare to us, Alaska Native people, American Indian people could contract those dollars and design our own healthcare systems. That was happening in bits and pieces all over the country, but in Alaska, uniquely, Alaska Native people said, we will do that, and they came together and developed a regionalized system. South Central Foundation is part of that regionalized system. We are a regional Alaska Native healthcare organization providing healthcare services to 70,000 people in the South Central region, urban and rural, and we co-manage the centralized hospital for all of the regions, which is also based in Anchorage. Next slide, Doug. We're going to talk a lot about our philosophy of care and what our clinical service delivery model is. But before we do that, I want to share just a little bit of data. Doug, if you could go to the next slide for me.
I know I'm trying. Why isn't it progressing?
Can you hit space or arrow? There we go. So before, I used to have the data slide sort of at the end, and then everyone would hear the philosophy and think, wait, does it work? This is why we have people from across the country and really all over the world coming to look at what we've done. Since we have developed a customer-owned system of care based on relationships, we have seen decrease in ER utilization, hospital utilization, this big recognition Daryl mentioned called Baldrige. But maybe most importantly is that at the beginning of our journey, every outcome, every HEDIS that you wanted to be high on, Alaska Native people were low on. Everything you wanted to be low on, we were high on. I remember in our journey when our goal was to hit the 50th percentile and be mediocre, we are now consistently above the 75th and often at the 90th HEDIS percentile. And we do that by really understanding what our community thinks, so our customer owner satisfaction, and at the same time, how our employees are doing, our employee satisfaction, and really considering those two as balancing measures. And we can talk a lot more about data, but that's just a flavor for why people look at our system.
The other thing to dispel right from the beginning of the talk is that somehow we are rich or different than everybody else or whatever, and that this doesn't apply elsewhere. So just to dispel some of the financial questions that people might have, a few minutes on money. So we have a very mixed revenue stream. We get some money through the Indian Health Service. It's about 40% of our money. 55% of our money is fee for service. So Medicaid, Medicare, private insurance. The way we get paid, though, is heavily bundled. So like our Medicaid, we get paid in a daily rate that's based on a Method E cost report by the U.S. government, but it is still based on visits. Get a visit, submit a bill, get a payment. Medicare, we're more like other people, but heavily bundled. And then somewhere around 18% of our revenue, maybe close to 20% now is private insurance. So Alaska Native people carrying private insurance that we bill and collect like anyone else in a fee-for-service environment. One difference is Alaska Native people never pay the copay or deductible. As April said, the government owes health care to Alaska Native people, so we are not violating the rules when we don't collect any copays or deductibles, because they should be able to get service from us without paying anything out of pocket. So we are the Indian Health Service. We are Medicaid, Medicare, private insurance. We are also HRSA, FQHC. We operate 16 community health centers, so we get money through the FQHC process. We are also the VA. We get paid by the VA when we see veterans. We do disability work. So pretty much we got our fingers in all the different streams of healthcare money. And it kind of paid off during COVID because we got our fingers into everybody's COVID pot of money. So from initially being afraid of COVID, we actually did pretty financially well during COVID, like lots of people did. But because we have so many streams of payment, it kind of additionally paid off. But we're not rich. The cost is right around, annualized right around $7,500 to $8,000 per person per year, all in. So we cover pharmaceuticals, dental, all the ancillaries and supports, all the way up through NICU, PICU between us and our sister company. So for outpatient, primary care, all the way up through specialties, surgical processes, hospitalization, all that stuff. And we include dental, optometry, and outpatient behavioral health in this number. We don't include residential treatment programs because we're trying to compare apple to other people. The national average in the United States is now around $12,000 And for high-risk populations, it's 15 to 25,000 per person per year. And we do it for about 7,500 to 8,000. We think and act as a whole system. We budget as a whole system. April mentioned our corporation. We have a sister company who we share with. We do more of the outpatient behavioral health, primary care, and maternal child health, and they do more of the inpatient adult specialty, subspecialty stuff. Between us, we employ just shy of 6,000 people, supporting everything from water and sanitation and construction of clinics and villages, all the way up through NICU, PICU, ICU, CCU, pretty self-contained, vertically integrated system. Everybody works on salaries. And the other thing just to say on money is that it turns out that if you give up revenue, as we do because of how we practice, even before COVID, 70% of our touches were virtual, often not reimbursable. But it turns out if you give up 30% of the revenue you could collect, but you reduce costs by 40%, your margin improves. Now that seems like basic math, but healthcare doesn't seem to understand this. All they think, all the answers to all the problems is more revenue, greater throughput, greater payments, more efficiencies, which all just have to do with increasing revenue. All right, we can talk more about that at the end, but just to dispel any thoughts that we're all that different from anyone else in the U.S. Back to you, April.
Thanks, Doug. So Daryl and group, the first two slides were, we've redesigned it. What are the outcomes? And how do we afford it? What do our finances look compared to others? We're going to transition now into what do we do? And this is where it gets fun for me. So we have a vision and a mission, and there are places in healthcare in the U.S., you all know them, that have some fancy vision and mission, but at the end of the day, all they really do is work on profit or margin. And for us instead, this is what we live, breathe, sing, dance, literally. Vidar and Daryl had a chance to see that in Alaska. The vision, if we close our eyes and imagine the future, what we're working towards is a Native community that enjoys physical, mental, emotional, and spiritual wellness. And we believe that each of us, and I can see you in the room, so if you could just sit in your body for a second and feel that you have a balance of how you are doing physically, mentally, emotionally, and spiritually. And that those things are inside of us in some sort of balance or unbalance at every step in our journey of life. And if we want to think about wellness, then we need to think about how we can impact that balance, that multidimensional balance. If you believe that wellness is multidimensional, that those things are connected, it changes how you design a healthcare system, what you think would be the right things to build and do if the goal is to support a community in achieving wellness. The mission is how we get to that vision. It's how we march towards it. And it's a Native community that works together. It's a system that works together with the Native community. The key word there is this idea of working together in relationship and in partnership. And we would say that the output of our healthcare system, the thing we work to create day in and day out, is not diagnosis or treatment plans or prescriptions. It's the quality of relationship that we can sit in with community. And we're very intentional about thinking about relationship at a macro level between healthcare system and community, and relationship at a micro level every day between care teams and the people and families who they are interacting with. Long time ago, Doug mentioned this, we started really thinking about language and words and power and how we wanted to understand our reality. And as we chose words, one of the things we did very intentionally is decided that the people and families will be called customer owners. So we never say words like patient or consumer or member to us. That reinforces the problematic hierarchy in healthcare, where you have a healthcare system that is expert and you have people who come in to receive something and they are asked to be patient and be in a real recipient role. And we want to break that hierarchy and instead say to our healthcare leaders, to our clinicians who bring all of their expertise to the table, thank you. Please bring all of your heart and your love and your expertise into this relationship. And to the mom, to the son, to the father, to the niece, thank you. for coming to this table. Please bring yourself and your heart and all of your wisdom and all of your expertise. And if we can change this idea of hierarchy into relationship and partnership, then we can have real conversations about what matters in the wellness of a family, and we can walk and journey with family together. We've been around for 40 years, but our big kind of growth happened in the 90s when the new native medical campus that I'm standing on today transitioned from federal to tribal operations. And one of the things our leaders did at the time, this is back in the early 90s, is they conducted what was like a big research study, and they asked the community, what matters to you? What do you want out of healthcare? And remember, what people had received was this Indian Health Service. You can only get in through the emergency department, and you wait until you're really sick to go, and if you can afford it, you go somewhere else. That's what people were used to. And when we asked them through surveys and interviews and focus groups, we asked elders and people in waiting rooms and people who worked in the system. They told us what mattered to them was domestic violence, child abuse, child neglect, behavioral health, and addictions. I want you to think about that list and think about, what is your mental model of what healthcare is? When we heard this from community, it gave us, I kind of want to say permission, but really it gave us responsibility, because we had direction from community who owns this healthcare system to start thinking about things that are way bigger than clinic visits and diagnosis and treatment plans. It really forced us to start thinking about whole person wellness, family wellness, and community wellness. And you can only get to those topics if you can build trust in relationship, so that you can open those conversations up and then think about the array of interventions that might allow you to walk with a family in their journey. As you can see, we did this big needs assessment again right before COVID, asked community. It's a lengthy needs assessment, but the top 5 were alcohol, drugs, tobacco, oral health, behavioral health, food, nutrition, obesity, and heart health. And you'll notice some of the things are the same and some are different. So we've got work to do, and that work is driven by the voice of our community. Next slide, Doug. When we asked people what they wanted out of a system, they said, we would like cleaner facilities, better facilities, places that represent our culture. If you come to Alaska, you'll see what our spaces feel like. They feel like spaces you want to bring your family to. People said they wanted access to their own primary care provider, their own team, somebody that they could talk to who would know them, so that they weren't just a number seeing a new person in the system every single time. And somebody there was just talking about a mom who said that she felt like her provider really knew her kids and she'd never leave that relationship. That's exactly what we're looking to build. Next slide.
Oh, in most large healthcare systems, there are actually competing systems of primary care in the same healthcare provider. So, but we don't tend to call them out that way or think of them that way. But generally, in most systems, you have a combination of competing systems. One is sort of disease-specific things. So kind of a center of excellence approach, where you go here for diabetes, you go here for your congestive heart failure, you go there for your HIV, all different places and different specialists. Problem is, people don't come in tidy little packages, especially those who cost us the most, right? So really complicated people probably have 5 or 6 different ones of those things. They have diabetes and congestive heart failure and end-stage renal disease and COPD. And so they end up seeing 5, 6, 7 different specialists, every one of which gives them a specific care plan and prescribes anywhere from 1 to 3 or 4 medications. So they end up with 5, 6, 7 care plans, maybe 20, 25 different medications. And the person that's supposed to integrate all of this is the person themselves, which is completely ridiculous because they're not really given any real information or power to do so. And then in our arrogant institution professional-centric way, when they don't do what we tell them to do, we call them non-compliant and in our judgmental way, which is ridiculous. There's a tiny number of people who have actual sociopathic disorders, but most people wake up in the morning and do the best they know how, and don't wake up and say, I'm going to go screw with the healthcare system today. So we selected one. We said we don't have enough money to do anything other than one core system. So we selected all ages family wellness and said we're going to create a very powerful platform for everyone. And we understand that health happens in the context of family and household and environment. And so we're going to try to have it be all ages. And so when you panel with us and you choose a specific primary care provider, your whole family, whether it's your genetic family, the people who live with you in your household, whoever's family to you, we try to empanel you into the same specific provider team so that this fabric is what we're addressing, not an individual in an exam room pretending they don't have a context in which they are living. So over the last 25 years, we've, with great constancy of purpose, developed and improved and developed this platform. So we've gotten to the point where now we can really do complexity, pregnancy, pain, addictions, trauma, all kinds of really difficult things comprehensively in the primary care setting. And we'll come back to specifically how we do that. Once you do that, the other thing you need to do is you need to have population-sized deep dive capability for niche populations. So you need to be able to get to people what are called severe mental illness or people living with lifelong mental challenges, addiction. We have a child and adolescent neurodevelopmental center for children who struggle with developmental challenges. Big emphasis on rehab, on family violence. We do things in jails. We do things with HIV people. So you need the powerful platform and then ways to get to these targeted subgroups that have particularly complex needs and also drive costs because, right, we all know that 20% of the people drive about 80% of the costs in healthcare. So you have to be really good at three things: at the generalist platform, very powerfully, at the subpopulations that are at highest complexity and risk, and third of all, you need to have the infrastructure, so the complexity infrastructure underlying all of it so that it's a very sophisticated, highly capable system, which we'll get to all of that in a little bit more detail. So far, we've established you need to have customer owners. Their relationships is absolutely everything. That you need community-based activities. That you need access to people who know you, same-day access for anything you want or need. That it needs to be in a way that works for the people on the receiving side. You need to have integrated teams with behavioral health, and you need to have facilities that work for you. This is, This is just a quick picture of where our integrated teams sit physically, and we'll come back to this a little bit about who's all in this team. But the point is that we de-officed everyone and put people together into functional subunits so that the primary care provider, case manager, case management support, all the co-located specialty people that are in primary care are all in a shared space together. Eliminated nurses stations, de-officed absolutely everyone, no private offices for anyone. And even before COVID, the vast majority of our interactions came from this environment through this device, which is how people communicate, learn, and support each other, called a smartphone. And so we were well over 50% asynchronous, virtual text, email, video, whatever you wanted to connect with us with, even before COVID. So we'll get into some more of those details, but back to where April took us to begin with, the fact that the clinical people and the customer owners are coming to do this in a shared responsibility where we bring technical expertise and they bring their lived experience and the expertise they have in living their particular life. And then together, we do this respectful partnering around their goals and aspirations, bringing our expertise into the and best practices into the conversation.
When people look at our system, if you can go back one slide, Doug, when people look at our system, I think one thing that they come to learn about is how we've approached behavioral health. I don't know if Doug mentioned that when we rolled out this super powerful primary care model in 1999, we were on the front cover of the New York Times around being one of the first advanced access models so that you can get in to see your provider that you know same day. The other thing we've been doing for a really long time is thinking about how to bring behavioral health expertise into that relationship. And so we have master's level behavioral health clinicians. We've been doing this for, gosh, I don't know, 18, 19 years now. And what I see happening is really generational change in how our community understands their orientation to their healthcare system, to their own behavioral health, and to the resource of behavioral health that exists in their system. So if I think a generation ago, we were really of the mindset that, don't worry, we've got behavioral health. It's in that one building over there for that one uncle in your family. And instead of that, my kids, who've grown up receiving primary care in our system have always known that a behavioral health consultant, master's level clinician, is going to be part of their integrated care team. And not only part of the team, but a compulsory part of certain visits that they're going to have over time. There's a story I share, I'll do it really quickly, where I'm a mom, I've got a kiddo with a sore throat, I'm a non-clinical healthcare leader, but I've got WebMD, so I've diagnosed it. It's strep throat. I put the kid in the, drop off the other kids at school, I've got him in the back of the minivan, and he says, hey mom, when we get to the doctor's office, can I see the BHC? And I looked at him, and he was like 7 or 8, and I said, why do you want to see the BHC? Do you know what those letters mean? And he said, Mom, I'm still in this pull-up and the other kids are having sleepovers. And I think if I talk to her, we can figure this out. So that is a story about my kiddo knowing that a behavioral health component is available to him in his healthcare system and that he can ask for it. And we got to that visit. I didn't call in advance. It's integrated into the primary care model. CMA comes in and I said, hey, can we see a BHC while we're here? And the CMA, I can remember him. He was a guy, kind of a cool guy. And he said, what do you want to see the BHC for? And my son said, no, don't. He did not want me to tell this cool guy that he was wetting the bed. And so I said, can we not tell you? And he said, no problem. And they brought in a BHC, and I did the April thing, the mom thing. I started talking, and the BHC said, hey, April, it's great to see you. I understand your son asked to see me. Can he tell me? And so I stopped talking. She very politely asked me to. She had a conversation with my son. They made a plan, and it involved me getting up at midnight every night. The idea there is if we can foster the comfort in talking to behavioral health for our young people, for all the little things in life, then maybe when life is really hard, they'll know where they can go to have a conversation about things like addiction and loss and grief and depression and all of the things that may hit their lives. So if we get good at those primary care relationships where we're talking really with families about what matters to them, one of the tensions that we work to figure out in our system is how much do we bring to the primary care relationship and handle in the primary care environment. We have integrated psychiatry. Doug's going to talk about this. And when do we really need a specialty service that we refer out to? And we have all the medical specialties, but we also have just a really robust set of behavioral health specialties that needs to continue to grow. Next slide. And we have lots and lots of ways. If we're going to be this customer-owned system where family is telling us what they want out of their healthcare system, then we need to be in the business of being good at transitioning power from institution to community and allowing community to have voice to give direction to their healthcare system. And we do that through advisory committees and health councils. Doug, I, and other leaders spend way more time sitting with community, sitting with elders, sitting with families, and getting feedback and direction. Every single step we take, every change we make in our system is driven by the voice of our community. And I'm going to give you one quick example about that. Maybe 17 years ago, I was new growing manager in our system. We had badges. You guys have badges in healthcare, and they were we had to reorient them so that they were not landscape, but they were they hung in a different direction so that we could use the new technology to open doors or something. And we asked all of the doctors and nurses and dentists, what do you want on your badge? And I figured out kind of how to manage all of that because there was less room on these new badges. And I went to leadership and said, okay, here's what I think we should do. And they said, well, what did community think? And that was just a tiny decision that we were working, I was in HR at the time, that we were working on making, that I hadn't asked community their voice on. And as a growing leader in this system, that's one of those moments where you just want to curl up under the table and die because you failed. And so the next day I set up a booth and I asked the next 150 people who walked into our primary care center, what should the badge say? And then that's what it said. It didn't matter what all the nurses and all their initials and all the doctors and all their initials. It was built on the voice of the customer. Most systems say that they have voice of customer, voice of patient, but it's really a check the box survey once a year, one seat on one committee so that we heard your feedback, but then we're really the experts and we'll decide what's best for you. This becomes the way that we do our work intentionally over time, is to listen to community voice. Next slide. And this is just in general, this idea that if we're going to get to wellness, it's not going to happen because we got the right diagnosis for pink eye and the right prescription today. It's going to happen because we're building relationships with families so that they become increasingly comfortable in being the drivers of their lives, self-confidence and wellness, that they are connected to their culture, that they feel dignity for themselves, and that we become their trusted partner to support them in driving their own success. Next.
So I know most of you are structural operational finance people, and we haven't even gotten to how we structure anything yet. We've just been talking at you about philosophy, and that is the core of what's different about us than other people, is other systems, is that we don't take the as is and then just tinker with it. We actually start with the fundamental assumptions. What are we existing for? Who do we exist for? And who then should tell us how the system and the structure should look like. So now we're going to get to a little bit more of structure, and this is what we've sort of established so far. The usual judgmental, paternalistic, at the convenience of the professional medical culture is being replaced with relationship, shared responsibility, customer ownership, story, and if you want to get technical, what is complex adaptive system theory. One more philosophy slide, and then we'll get into specifics. This is kind of, again, because you all have been to way too many years of school, we have to put it into a graphic, and you won't understand it. So this is just a, two variant diagram. So you have acuity on the bottom and control on the left, and it's a percentage. So if you have two variables in a percentage, one has to go down when the other one goes up. So on the far right-hand side, this is about 1/3 of healthcare, 1/3 of healthcare expenditures anyway, which is high acuity environment. So I get hit on the street, EMS scoops me up, does things to me, the ER does things to me, the operating room does things to me, intensive care does things to me. So in those situations, the person or the patient or the customer owner is passive, and the system is doing things to them. On the left-hand side, which is about 2/3 of healthcare, primarily driven by people living with chronic conditions, is a lower acuity environment. And as soon as the customer owner has involvement, they start to control what happens. So whether medications actually get picked up, whether the medications get taken, whether they quit taking them because of side effects or drug-drug interactions, what they eat, how they exercise, whether they use too much tobacco, alcohol, or drugs, what their sleep habits are, whether they lash out violently when frustrated. All these things drive 80 to 95% of their health outcomes and are under their control. So this is not, do we want to give up control? This is acknowledging the fact we've never had control as soon as a person is actively involved in the conversation. So we embraced this rather than sort of being frustrated and said, we're going to completely change everything that we do, since this is actually the reality within which we live. Just one really beautiful picture of our beautiful big 90,000 square foot clinic out in the Matsu Valley, just because some visuals are kind of nice. But one of the things we do is create really gorgeous facilities, because the issue of pride, honor, dignity, self-confidence is a very, very major part of the whole conversation. And so how we do facilities and playgrounds and external looks and how much money we spend on the public areas is a very big issue for us, because pride, honor, dignity, we don't want to be that, second-rate safety net native place. We want to be the most beautiful, prestigious, gorgeous, and effective place in town. All right, here's the structure we're at now, 25 years into this super powerful primary care platform. So in the middle, you have the customer, owner, and family. And then they have one primary care provider who has one case manager who's supported by medical assistants, one or two medical assistants, is something we call a case management support, who's a non-clinical, generally lots of lived experience person from the community who works very directly with the case manager. And those are the people who you're in the most intimate relationship with. They're available to you all day, every day, 5 days a week, period, for anything. And we've tried to make this now into the hub for medical and behavioral and social needs. So anything related to your health, these are the people available, same day access, all day, every day. We've maintained this now for almost 25 years. And then in every single clinic sitting right with them is the next circle. So there's two behaviorists or BHCs. We'd like to get to where there's one on every single team. It's an issue of money and recruitment. We haven't gotten there yet, but ideally your most intimate team is behavioral, medical, and then by extension, social. And in fact, April has made some changes in leadership recently, and the new executive VP for primary care is actually a master's level behavioral health clinician who's also very good at management and senior executive leadership. Well, that's on purpose because primary care is no longer medical with a little behavioral appendage. It's the hub for absolutely everything happening in your life. So there's two behaviorists, a couple midwives, a clinical pharmacist, a dietitian, and the CRS is community resource specialist. So this is like a placement connect to community services person. And all those people are just co-located, integrated. They don't have separate schedules. This is not co-located mental health. This is integrated behavioral health. And then the next circle out, and people in sort of the olive green on this picture, are people shared across multiple primary care clinics. So they're still physically in primary care, but they're not in every primary care clinic. They're shared across several primary care clinics. So there's 4 psychiatrists, there's an HIV expert, there's home visiting people, there's lactation people, there's people who help you make the most of your electronic health record, there's a fellowship-trained chronic pain specialist, there's a 30-year pain expert psychologist, there are 2 physical therapists who are expert in pain, and then there's some people to help us with high-risk things that occur among Alaska Native people in high proportion, like colorectal cancer. So all these people are physically in primary care, not separate schedules, just all there as resources to be immediately available for whatever people need. So this is how we bring this expertise to people. So addictions, pain, mobility, pregnancy, reproduction, behaviorists, HIV, all that happens in primary care, not as referrals somewhere else. By the way, just a little note, our pediatricians and pediatric case managers are now also in all ages primary care so that you get a generalist and a pediatric specialist both. You don't have to choose between them when it comes to the health and healthcare of your children. One little outcome, we could talk about outcomes all day. As April said, we moved from the bottom 5th percentile to the top 75th percentile and even the top 90th percentile in just about every single clinical outcome. HIV, I'll just give you the example. We have one HIV specialist nurse who's done nothing but HIV for 20 years, who's in primary care, who helps all the generalists do perfect HIV treatment and support. So you just see your generalist as an HIV positive person. There's no HIV clinic, no HIV Thursdays. You just come when you want to. And the generalist provides perfect support because there's a specialist whispering in their ear to help them do a perfect job. And we have achieved 87% of our HIV individuals have undetectable levels of virus, which is world-class outcomes in a population where we don't get to fire anybody. So our denominator is literally everyone, whereas in HIV clinic outcomes would just be those who choose to go to the HIV clinic. So extremely effective way of doing business. The people on the outside, the pink people on this diagram, those are destination specialists. We still do refer people to specialists who are sitting somewhere else in the system. But even them we try to train to help the generalists. So like the cardiologists help the generalists with their cardiology challenging people. And in fact, 8 out of 10 potential consults are averted by the cardiologists helping the generalists do a great job with cardiology challenging people, just like the HIV person that I mentioned. So this is the structure. We could spend a whole hour just on this and how all of this plays out, but we don't have time. So I'm going to keep moving ahead. This is just to remind you what I just said. We bring expertise in HIV, diabetes, pain, complexity, sort of generalist complexity. We do a whole thing called aging well, some amount of palliative care. We've co-located psychiatrists, addiction people, pain people. We have home visiting extenders, lactation, midwives, pregnancy, and some amount of sort of logistics related social work, all in what you call primary care. And people say, Doug, you have like the most expensive primary care system in the world, but most of these people already existed. We just reposition where they sit in the system. So these are our population scale approaches. And again, we try to have it be the hub for medical, behavioral, social, and oral health. Same-day access guaranteed for 23 years. 50 to 70% of it asynchronous virtual. People connect with us however they want to. which means primarily this thing called a smartphone. We bring specialists into primary care, and then we have all these projects that we continue to expand the capability. So these are current projects, fully integrating pediatrics, so there is no longer pediatric primary care as a separate thing just in the all ages clinic. Our ability to handle more and more complex children. We have this thing called New Generations, where we've now taken on responsibility for parenting. So we've eliminated this business that you have prenatal care and then postnatal early childhood care. You just have support for you as you get pregnant and create the miracle of new life. We did a lot of things around anticipatory guidance as you age, called Aging Well. We're big into wearable devices. How do you use the stuff on your wrist, the scales, the blood pressure cuff? How does all that information come in through an app that we created? We have our own app to make the best use of those devices. How do we do home visiting optimally? And then, as already mentioned, how do we help people live with pain, addictions, palliative care, advanced directives, and all of that kind of stuff. And if you notice all these efforts here, none of them are physician-centric, and none of them are really based on office visits. This stuff can be done through communication, through this device, and through being continually available to people when, where, and how they want to be connected with. Then we have niche groups that we pay particular attention to, and I'm going to turn that over to April.
So we probably won't have time to go into detail about how we think about where the primary relationship sits. I'll just say this, that we're redefining what the word primary means so that it's not a synonym for medical care. And then we're acknowledging that there are people whose primary relationship will be different. So for adults with persistent mental illness, one of the programs we have is in downtown Anchorage by the soup kitchen and the shelters. It's called Kiana Clubhouse. It's a clubhouse model with a therapeutic overlay. And we've reverse integrated medical primary care into a largely behavioral health environment. Serves 115 people at very high risk of experiencing homelessness. And on the start of COVID, day one, all but 5 were housed. So we think about things like addiction treatment and how at that moment in your life, that's where your primary relationship is going to be, and what is the transitions from primary care and discharging back into primary care post-graduation from treatment. Elders program can become the primary relationship-based place for an elder who's receiving a whole bunch of their in-home services and transportation in and out of medical and other environments. We have lots of focus on kids, traditional healing, complementary medicine. What are all the different parts of our system that we should focus on? Next slide. A lot of people come to our system to look at our current service delivery model, and we're doing cool stuff in how we're delivering care. But the infrastructure behind it that allows us to be a continually learning system is, I think, actually more important than our service delivery model of today. So how we think about workforce and workforce competencies. For us, workforce competencies means understanding our orientation to community. How do you work in your job in relationship with customer owners? How do we work in team-based settings? There is some clinical hierarchy on clinical teams, but really we're peers trying to get to same outcomes, and we have same dashboard of measures to achieve collectively. We do lots of work around thinking about how we improve and how we build improvement capacity into the design of our system. So most systems say we want to improve, but you just ask the people who have full-time jobs to tack more on for that improvement to happen. And we've really built the infrastructure for improvement into our system. We become highly capable at understanding our data and thinking about population health kind of at the full population scale size. I think one of the big moments for us years ago was when we decided that EHRs are never going to do more than report to our payers how to pay us. And so we needed to build what we called a data mall, which sat above our EHRs, held all of our data, and allowed us to produce our own measures for understanding wellness for our community. We hire with Alaska Native preference in how we hire and how we promote. So if we want to be a community-owned system, lots of intentionality on how members of our own community can grow, both as operational leaders and as clinical leaders to, in fact, become the leaders of the system for tomorrow. I'm a product of that. And then a whole bunch around HR and IT and data and research and infrastructure. Next slide. I want to talk a little bit about urban and remote. I'll do this briefly because I'm not sure if this is important to the work that you're thinking about, but I think that far too often when we think about rural and remote healthcare services, we attempt to just take the urban model and say, oh, okay, we're going to try our best to recruit people to do that same thing out in our rural and remote settings. And that's really not going to work. What's going to work is to engage with a local community, to become the creative drivers of what that on-the-ground healthcare system can look like, to find in that community people who can become the healthcare providers, who can be on the health council, who can be the local behavioral health providers, and then train them to deliver that care locally and connect them with the clinical resources that they need through relationship in town so that lots of that clinical care can be delivered in a local community with referrals patterns that go from very small to sub-regional hubs into regional and into statewide services. That's a whole hour-long conversation if we want to talk about rural and remote care. Next slide. This is our last slide. So what do we know that we need to do? We need to continually remind ourselves that the healthcare system is not about us healthcare experts and that we don't know the right answers. That instead, what we need to focus on is how we sit in relationship with community and with each other on these healthcare teams. That what our kids will need out of their healthcare system is unknown to us, right? What will my grandbabies need? Who will know what they need? They will. And our job as healthcare is to continually be driven by the voice of families and allow families to tell us what they need out of their healthcare system. So next slide, Doug, is our conclusion slide, but I know you're looking at a slide deck. So Doug, if you can unshare screen, I think they'll see our faces again, which would be nice because PowerPoint is, can you unshare screen, Doug?
I can, but I want them to see this as we close.
The Baldrige Award.
It's better. It's less cost,
Yeah.
happier people, less turnover, better outcomes. It is the triple aim. It is the quadruple aim for less per capita spend. By far, about half of the per capita spend that, according to U.S. healthcare, we really should be spending. So I will stop share, and we'll back to personal relationships.
Awesome. Thank you so much. So a couple of things I'd like you to expand on just a little bit as we go into kind of a fireside chat here. The right people for the right job. Doug, I heard you say in healthcare, we train physicians who are good at tests and know how to build systems, but that's not what we're doing in healthcare. What we're doing in healthcare is getting in the messy experience of being in relationship with people. Talk a little bit about this. There is a certain percent of healthcare that needs to be more of a manufacturing approach, but 70% is that messy, and we need to have the right people in that. And it's not the people who do well on tests often.
If you're spending 20% of society's wealth, which is what has now happened with healthcare, you better be able to explain how you're adding immense value to society. And value, modern medicine thinks value is an accurate diagnosis and giving them a treatment plan. And then we're done. And that's ridiculous. That's not value. Value is them doing something different after encountering us than they would have done had they not encountered us. So getting their meds, taking their meds, following the instructions, changing lifestyle, parenting better and differently, dealing with underlying issues like generational violence, generational trauma, addictions. If they don't do something with what we gave them after they encounter us, we've not added value, which means our number one skill we need to teach and we need to hire for is the ability to influence. So through story, through trusting relationships, through immediate access, if we can't influence, we don't, for the 2/3, right? So 1/3, there's value to mechanics. For example, I had a total knee replacement 10 weeks ago. That was mechanical. I need my orthopedic surgeon to be really good at whacking things out and putting things in. So that is 1/3 of healthcare. But 2/3 of healthcare, which is the rapidly escalating cost part, is really about managing chronic conditions. The big ROI here is managing chronic conditions. And then all the wellness and fitness and health is sort of gravy on top. But the real ROI is much better, less expensive people living with chronic conditions that they are in control of. So our ability to influence is where you get value, not diagnosis, treatment plan, and then judging them not compliant. April, you want to add?
Yeah, Doug, can I just add to that? I echo everything Doug said. And if you take that one step farther and you say, okay, how does a healthcare system become in relationship in a way where we can provide influence? And the answer to that question is to ourselves as humans be in relationship with community and planfully intend to be influenced, right? To be influenced by what community and families tell us matters in their lives. What are the ways that we can be their partner and be in their lives differently than how, a doc who likes Fridays off to golf and thinks that the system's going to be built around him and the payer and what they think you're going to do and the law and what they think you're going to do. But instead, what does family think? And can we have a trusting relationship enough to create voice for families to tell us and to be willing to be influenced to design what we do differently so that we, through that relationship, can then influence them. You see how that goes back and forth?
Well, and expand on that if you don't mind. How do your provider teams really get that last hardest group to move? I know you've referred to your medical assistant support people as your secret sauce. Talk a little bit about that.
Yeah, so as April said, when we started all this, we thought we were being really aggressive and brave and proposed to our board that we try and get to the 50th percentile on health outcomes because we were in the 5th. We were the bottom 5th. And we thought that was really aggressive. And our board actually scoffed at us and said, oh, so you want to be average? And we said, yeah, we're a long way from average. And they said, no, we're going to be above average. So that was the 75th percentile. And just through sheer really good general relationship and clinical acumen and partnering and all that, we do pretty much all our teams get to 75th percentile performance. But there have now been 5 clinical teams that have moved every one of their clinical indicators to the 90th percentile. And I'll go spend a half a day with any team that accomplishes that. And every single one of them says the way they moved that last bit was by working through their case management support, which are almost all middle-aged women who have had kind of hard lives and a lot of lived experience and know just how to talk and relate and work with people who are hard to reach and hard to influence to do something different than they would otherwise do. And this goes back to just the fact that if you're going to get to cost in healthcare and outcomes, you have to remember the 80-20, that 20% of people are going to drive 80% of cost. And those 20% of people, by and large, are not your most confident, not your most self-capable, not your show up on time for appointment people. They're some of the most challenged, hardest to reach, don't come in, miss appointments, come late to appointments, and our rigid, you must show up on time or you won't be seen. And, at our convenience in our institutions, so let's just play out the average encounter, right? So you have to take off of work, you have to arrange childcare, or you have to get transportation. And then you get a hold of us and we make you wait 2, 3, 4 weeks before we even see you. Then you have to make this massive effort. To have a healthcare appointment is at least a half day, if not a full day effort. And a lot of these folks are working 2 and 3 jobs. It doesn't want to give them a lot of time off. And then they have to come across town, and then we make them wait when they show up, and then we rush them through, and then we don't let them say hardly anything. We tell them, here's your label, called a diagnosis, here's your plan, and if you don't do what I said, we'll call you non-compliant when you come back. Literally everything about that is horribly designed if you're actually trying to get to the 20% of people who drive the vast majority of healthcare costs. Completely ridiculous from a population health. And the fact we now control 20% of this nation's wealth, and the return on that investment is terrible.
We got some questions going up. So Lee, go ahead. Here, use this one.
A lot of vendors have been coming out recently based on the following assertion that it is too difficult to get great healthcare built in really rural communities, and so we need to leverage technology to deliver full virtual advanced primary care. And they would purport that they could deliver something like Nuka, but do it through all virtual modality. And I have some opinions on this. I'm very curious to hear what your response would be to someone who says, you know, let's give up trying to build in-person assets and move to all virtual.
You want to take that one, Doug, or you want me to? I love how there's so much bias in how you ask that question. I'm just cheering you on for that. Go ahead, Doug.
Oh, you want me to start?
Up to you.
Okay, that's a bad idea. I think we just spent the last 45 minutes trying to convince you that relationship and connecting and story and trust and meeting them where they are on their journey is the magic here. It's not just the technical delivery of knowledge and the access to prescribing and pharmaceuticals and tests and whatever. That's all secondary. People have to take ownership of their journey. We have to meet them where they are. We have to support them on their journey. They have to trust, and then they have to do something different after encountering us. And the ability to get people to do that, especially the 20% that drive 80% of the cost, is very, very low if you don't have some human element of connection and trust and story. So what we do is also, and this was the one slide that April covered, that said, you know, the idea that somehow you're going to entice doctors, pharmacists, and nurses to all go live where they don't want to live by giving them bigger and bigger bribes is ridiculous. So then the fallback is, we'll just do it through technology. Well, that's because you haven't questioned the medical model. You still think you got to have a frickin' doctor who tells you how it is and then judges you not compliant when you don't do what they say. And you have to have a visit, an office visit. For the last 3 years, I've headed up a national effort through the Leadership Alliance called The Office Visit is a Dinosaur, because it turns out probably 70, 80, 90% of what we do, you don't need a visit, either in person or virtual. But what you do have to do is establish trust and relationship, and then you can have all kinds of asynchronous ways through technology and so forth to support people. What we do is we hire locally in the town or the village with no healthcare background, but people who want to live there and are the right kind of people to have influence. And then we train them up gradually, more and more skills, and we support them with the technology. So we do, our primary care teams have local people on their panel, and they also have 1, 2, or 3 remote sites. And they provide all day long, same day access to the local providers who are minimally skilled people from the community that are trusted, that we then support. And we have amazing technology, broadband. You can do EKGs, x-rays. You can take pictures of eardrums, pictures of the fundus of the eye, pictures of the throat. You can do handheld ultrasounds, all this technology that you need someone sophisticated to interact with, but that person can be at a distance, but supporting someone, a person who's physically there with the client, the customer owner, the patient, in relationship, that's supported by the knowledge and technology remotely.
Can I just add to what Doug's saying? It's really questioning the existing medical model. And as we've grown this community health aid, behavioral health aid, and dental health aid therapist, these modalities of local community members who you train up, it comes with a lot of resistance from the medical community, right? So I can remember as we were talking about how our state Medicaid plan would reimburse for community level behavioral health aids, there was somebody from a big system in the room in Juneau, and he said, I'm not getting on board with April and all of her people who don't have degrees. And the room just went silent, like anybody would dare say that with me in the room. Same thing happened around dental health aid therapists, huge resistance from the Dental Association at the idea that community members could be trained up to be the on-the-ground dental providers. But it turns out that people in these small communities are going to be there as they are growing their babies. And so we need to be able to provide prenatal care. How well can we do that with the backup and support through relationship to the providers? And when we say backup and support, what we mean is that those local community members who are the on-the-ground connectors, both are skilled at being in relationship with community, but have a single primary care team in Anchorage who travels to them multiple times a year, who they become in really trusting relationship with, so that they can say, hey, I don't know what's going on for this particular elder right now. I'm not picking it up. What do you think? Should we bring her into town? How are we going to handle that? And that can only happen when there's really trust that happens through relationship across parts of our healthcare system. And the U.S. broken healthcare system, which is a bunch of islands competing for money, has not figured out how to trust each other in order for us to maximize our delivery of care for the good of community.
Can you expand on that and talk about how important it is to you to allow autonomy within each provider team? Sure, they have to meet certain standards, but how critical it is that there's choice, agency, and creativity on the part of every single team to do it what's best, how they want to work together with their panel.
So Daryl's been through our 3-day core concepts training. This is a training that I lead every single time with every group of new employees. It's 3 days. I'm doing it 11 times this year. As a CEO, I'm spending 33 days with new employees, really practicing how we enter relationship with each other. And it turns out we are not all the same, right? We each there's a lot of different tools and ways to think about how we enter teams, what strengths we bring to teams, and how, if we can understand how other people are different on those teams, we can actually do things better as a group when we learn to respect and trust ourselves and respect and trust others through the power of story and relationship with each other at work. And if you believe that, it means then each team is going to have a different dynamic, because the nurse and the doctor and the CMA and the case management support are humans, and they each have a life story behind them that brings them to where they are at today, their expertise, what they're passionate about, their emotion, how they organize their work in their minds. And we don't want to have one way that teams are supposed to function. We want to develop the capacity for teams to know each other to function well. So one of the examples I give is if you have a new customer owner on your panel and that person's coming in for the first time, I am not going to tell you what it looks like to build relationship. I can't say you should look them in the eye and then say hello and then smile after saying hello and then sit down with them. And then, we can't dictate that for people. We have to help them develop that organic skill to be in relationship with each family. And as you know, with your own family members, your relationship with your auntie is different than your relationship with your uncle, right? And you figured out how to navigate that. We want to trust our employees to figure out how to navigate differently relationship with one family compared to relationship with another, relationship with the nurse on their team differently than the relationship with their CMA on their team. And they have to do that in organic human relationships, and we're going to support them in becoming more and more expert at the quality of relationships that they could be in. And just one more thing I'll say, it turns out if you understand factors that build resiliency, which drive wellness, the quality of relationships that we have in our lives, knowing that we love people who love us back, that we trust people who trust us back, that we see dignity in others and we see dignity in ourselves, is a driver of wellness. So just by being good at relationship, those relationships themselves drive wellness as an outcome.
Thank you.
And since all of you are overly educated and have spent way too much time in academia, there's a chart, which is now on the screen. Hopefully you can see it. That comes from complexity science, that's called a Stacy diagram, that puts us into graphic terms. What April just said. This is the same thing that April just said. So if it is actually possible to eliminate variation on the x-axis, and it's possible to have certainty as to the one exact way to do it every single time, which is certainty on the y-axis, then you can protocolize and standardize things and make everybody do it the same way. But that doesn't happen with people living with chronic conditions. If you have diabetes, not all diabetics are the same. You can't eliminate variation, but variation is not infinite. There are probably 10 sort of subtypes of diabetics. And on the certainty side, there are better and worse ways to approach the treatment of diabetes, but there's not a one size fits all. So you have medium variability and medium certainty. So you're not in chaos. You're not in do whatever you want. You need to know best practices. You need to be clinically outstanding. but you need to adapt to the person in front of you, meet them where they are, as April just said very, very well. And that puts you in the middle here where it says experimenting, dialogue. You obsess about the target, but not necessarily the process, creativity, and allowing positive environment. So sometimes we talk about tight, loose, tight management theory, where we obsess about the philosophy and the principles, and we obsess about the outcomes. But in the middle, we're pretty loose about how you organize your team, your day-to-day schedule, and the way you approach the specific person in front of you around this challenge of living with something called diabetes. So I'm just adding the academicized for those of you with too many years in school that you can't just understand common sense anymore. I give you a diagram.
One more question, and then we're going to give Lee a chance to talk about the HTA, direct primary care strategy, and we're going to open up for questions. So talk about your approach, which is aspirational, versus epidemiologist's approach, which is deficit.
Oh, that's a trigger.
We have a tribal leader on our board where this is a passion conversation for her. What good does it do when academia labels all of the problems with Alaska Native people? And if you wanted to write a paper on that, you want to research it, and you want to publish all the ways we're bad, you could do it. And what will you have done? You'll have harmed and hurt a generation. What if instead of that, instead of the ACEs, we're going to label the number of times that you've been harmed and tell you that that's going to be the driver of what happens next? What if instead of that, we were able to really quantify our resilience and our strength and our relationships, our creativity? I hope that if you tell someone about this talk, you don't say that Doug Eby was really great or April Kayo. I hope what you say is that Alaska Native people are doing something really amazing. Look how strong they are. And Daryl, it's a very leading question because I think you know our answer to it, which is we can choose the paradigm that we want to think about, and we can have an illness, diagnosis, treatment, symptoms-based, or we can talk about resiliency and recovery and strength and dignity and pride. And those are choices that we make. And we've been making the wrong choices for a long time.
Epidemiology just means the study of a population and their health attributes. Unfortunately, medical people list nothing but the negatives. And there's nothing about the definition of epidemiology that says it has to be that way. You can list just all the positives, enumerate all the bright spots, and across different locations, what are those things in common? And then that tells you what to fund and support in order to move everyone to a better place. There's no reason epidemiology has to be 100% negative as it currently is. It's the oppression of the medical model, once again, doing harm.
Thank you. Lee, do you want to talk about the HTA movement? And if you got questions relative to that here, and then we're going to open it up for just general questions. Stand or sit right here. Okay.
Yes. So, Doug and April, in conversations with you and others, it's become apparent. I work with large employers, mostly in the lower 48, who have, who are operating in 2,000 or 3,000 U.S. cities. So they're all over the place, every state, every time zone. About 5 million total families, and we've seen that primary care is evaporating. At best, you get 2 months of wait time for 5 minutes. At worst, you're just going into a place where they're incentivized to refer. So we said, okay, we need more independent primary care. Where can we find them? We have been successful in finding independent, value-based primary care down here in the lower 48 in different cities and towns who are taking a subscription-based payment rather than fee-for-service. So they're aligning the incentives that way. They are, by and large, integrated in their communities, and they're often fairly entrepreneurial. They're not all highly standardized, but they are engaging in different ways to deliver great care. And so the problem, though, is that all of them say, hey, I don't take insurance. You got to pay me just a flat regular fee. And I don't know how to bill claims, or maybe I could, but I'm not going to tell you anyways because I don't do that. That's not how we operate, right? And then I go to my large employers and say, hey, we need to work with these Like step one, we've got to get value-based, aligned incentive access with a physician who we can see and visit and build a relationship with, right? Like that's our first baby step. And the problem though is that in order to pay these people directly, either the patient's paying cash, and about 86% of our people can't afford to. And if we give them money to pay cash, they will spend it on groceries. They're not going to go and pay the subscription to the doctors. So we have to find a way to pay these physicians directly for the majority of our population who they're just not going to do that expense on their own. And unfortunately, if you're a large, Fortune 30 company with 300,000 families that you're covering, you can't do 1,000 little onesie-twosie contracts with different primary care all across the country. And you have to use the system you've got to pay them, which is an insurance company. So we had this huge problem. So after working on it for 3 years, banging our head against the wall, redesigning the program probably in excess of 70 or 80 times, we now have a model that is enabling us to activate independent, value-based, membership-based primary care sort of across the country, and pay them a membership fee on behalf of our employees through an insurance company without forcing the providers to change their operating model. This is necessary, but it's not sufficient. This is still just our first step, right? When we look at your concentric circles, we're just trying to get, I think we've got 3 of the little images of people in your center circle, and we don't have any of the other stuff yet, right? We don't have the olive green or the pink outsiders or any of the others yet. So we're just getting a baby step, but we believe that if we can lock down that coverage in cities and towns across the country, we can have an open dialogue. We're paying them a value-based care, and then our hope is over the next 2, 3, 4, 5 years, we can start to follow your example a little bit and start to integrate more of those personas. We can get our AIDS specialist and our colorectal screening person. Maybe it's not colorectal screening in the lower 48, right? Maybe it's, I don't know, something in cardiology or something like that. But we'll be able to start getting our personas that we can start connecting into this system and do that across the country. That's our hope. And that by having highly thoughtful referrals, we can start to choke off profiteering systems so that there is a consequence for profiteering, that you just don't have patients show up anymore. And hopefully that starts to realign incentives downstream.
Do you want to take questions?
Absolutely, yeah.
Anybody have questions for me? Either Deb or April or anybody?
So my question is, if this is a baby step, fast forward 5 long years, we will have lived through even more consolidation, vertical and horizontal. Will there be an ecosystem there to continue building out those concentric circles in 5 years, given the pace of consolidation in the market? That concerns me.
This is my thought on that, because I think about this every day. There are 2 competing incentives that are both extremely forceful. One of them is the profit motive in the carriers and the hospitals, who are doing exactly what you say. They are buying up every doctor, locking down access. All of our specialists are on somebody else's payroll. The other counter incentive or rebellious insurgency appears to be heavy dissatisfaction among all those individuals who absolutely hate the predicament they find themselves in. And in speaking with our physicians, it's funny, we talked to doctors in the different towns. We were in Rochester. Rochester is a desert for value-based care, for instance. Just weirdly, as a bit of trivia, there's only one direct primary care physician in Rochester, Dr. Petrovic. She's this highly rebellious, I think she's Russian, I'm not sure, but she's like, everyone tells me not to do it, but I said I'm doing it anyway, and to heck with them, and she sort of breaks out. She's, I take care of my patient, every patient, top to bottom. You can buy insurance if you want, but you just need Dr. P. So in visiting with her and others, it's apparent. We said, well, hey, if we can fill up your office, what do we do next? Because I've got 10,000 families in Rochester. The greater metro area has over 1 million people, and there's only Dr. P. And she says, oh, I have like 20 friends who are all begging me to do this. She's like, everyone wants to escape the system. So we've been thinking, I keep thinking of it as I call it a necromancer effect. We need to bring these people back out of, where they've gone to rest, and we need to bring them back into independence. But I feel like there might be a way to accomplish that if we can drive enough business and demand into value-based care that will draw people back out of the beast. My hope.
Can I make a comment on that?
Sure.
I just wanted to say that I think that if we do healthcare better, that the folks who got into this field for a reason are going to be attracted to that, right? And so when you think about what will be the drivers of what healthcare will look like in 5 years, I agree with the concern around consolidation and powers of big systems and hospitals. But I also think there's going to be some power in the vote with your feet workforce, who are going to want to be in places where they can make a difference. And just from a workforce perspective, I think the other thing that's worth thinking about that, I think we said a little bit about is that wellness doesn't always come from talking to somebody with lots of initials. There's a lot of ways by bringing community together for people in like experiences, we call them learning circles, or by talking with a community member who speaks like you and lives in the same kind of place where you live, you can have a real conversation about a mammogram or a colonoscopy. I think that thinking about workforce differently and the places that can really attract that workforce to deliver care are going to have, they're going to have a foothold, and that's something to build on.
I have a question for you, Doug and April. As we think about this, the future that we want, where we are coaxing the right kind of people to leave the W-2 working for Optum and come back out and become independent again, while they're with Optum or with the local health system fee for service, they've got 3,000 patients. We think that's too many. Everyone acknowledges that that's not even real. We bring them back out, and now they have 800 patients. Am I leaving 2,200 families out to dry every time I convert one over? I don't think that's the case. I think that also might get back to the concentric circles, but I need your advice on how I should think about that.
So because I'll answer first and I'll pass to Doug, because we're responsible for the entire Alaska Native community that resides in our area, I always give pause to the idea that we're going to create something boutique that people who can afford it will get it, and figure out how we can ensure that what we're building is really accessible to everyone. And that's just a value premise that I have as we rethink what the U.S. healthcare system can really look like. And I'll just mention, I think Daryl said this, that when we just came out of last week having our Nuka conference where we had, it's a small conference, 150 guests come from all over the world. It's not a lot of U.S. healthcare because what we're doing is much more like sort of population health. But I think that if you're afraid to pull people into a better system for fear that you make the worst system worse again, we'll never get anywhere.
Yeah.
Do you want to add to that, Doug?
Oh, yeah. Do I have 15, 20 minutes?
Yeah.
Several comments. So when we tell our story of what we've done, it's not uncommon for there to be an older physician who speaks up and says, oh, that's how we used to be. The country doc who was, knew everybody, knew the grandma, grandpa, the aunties, the uncles, and followed them all for life and got great trust and, saw them in the grocery store and saw them in the football game and and so forth. So my answer to that is yes, actually, we have recreated the old country doc, but on a much more sophisticated platform with a whole lot more teammates. So my problem with the small panel concierge practice is that it's still very doctor-centric and not scalable to whole populations or the whole country, and very kind of VIP exclusive. And they tend to skim off the top. They tend to get the, personally motivated, high self-confidence person who can afford to pay an individual premium, and the whole 20% driving 80% of the cost. Very few of those people can play in that game. So I understand the attractiveness of the boutique, don't take insurance, give me a fee, and I'll give you concierge service thing. But I think it's terrible, and I think it's destructive to our society. Our society helped pay for the education of every one of those doctors, and they owe society. And so I believe in the country doctor relationship part, but with very extensive teammates and in a very sophisticated platform. So I think part of the answer here is, rather than mega corporations that people sign up with instead of United Health this way and Nuka this way, that there's room for, especially employers, people with money, so government, employers, to create infrastructures that can support people in lots of different hiring realities. So yes, you can be your own independent practicing physician, but you sign up with us and we'll give you the data, the evaluations, the whole system support, and all the training, and we'll help you build more integrated teams and all that kind of stuff. You don't have to be employed by us, but we represent employers and payers, and we're going to provide the infrastructure on which your individual work can then happen. So I think there's a lot of ways to do this, and this isn't a 5-minute conversation. I think what's the economic and employment and structural platforms that can make this happen? I think there's a lot of ways to do it, but the old country doc by themselves. So the Scandinavian countries and Europe in general, but especially the Scandinavian countries, get a lot of attention for their very extensive social services. So as a society, they've created, let's take Sweden, one of the highest performing countries in the world. We've done a ton of work in Sweden because they realize they have great social supports, and they have great hospitals and great specialists employed at the hospitals, but they have crappy primary care because it's still little tiny practices all over the country that are on their own, afloat out there in the wilderness, trying to do the best they can in a society that's passed them by. You need a platform. You need a way to pull all those people together, to make a system out of them, to teach them how to do teams, and to give them the infrastructure, the technology, data management, population health capability, infrastructure in which they can then participate. So Sweden actually gets this. In a year before COVID, they launched a national initiative to reinvent primary care, understanding this problem, and we were the system that they were going to emulate. But then COVID hit, and the whole thing, like many things during COVID, just went completely to heck, and they're just now trying to reinvigorate that program. And this is true all over the world. You go to all over the world, and you find these sophisticated hospitals employing specialists and doing sophisticated, fancy medical stuff. And then you have some kind of social sector over here, and you have these primary care non-systems, little mom and pop shops that are just not capable. They can do relationship, but they can't do much else besides that. And they're not effective in this game. And these little concierge practices are an awful lot like that. So they're not the answer. They're not scalable. They're taking advantage of society. They got their subsidized education, and then they're just skimming off the top, the easy people, and making a whole bunch of profit. I understand the attraction, but it's wrong. Doesn't get to the 20%, driving the 80% of cost, and it's not part of a system and doesn't have the sophistication needed. One other thing, if you're running out of doctors, like in our system, we employ twice as many PAs and nurse practitioners as we do doctors. Mostly they're not primary care providers. Mostly they're coverage people, helping cover when people are out and so forth. But some of the super good PAs and nurse practitioners are primary care providers and have their own panels and so forth. So if we did get to the point where we had 1/3 as many doctors as we currently have, we just make them more the tip of the iceberg. They would do less and less, and they would be more and more the sort of sponsor of all kinds of other people. If you take a good nurse and a good pharmacist, you really don't need a doctor. If you take a good nurse, a good pharmacist, and a home visitor, you really hardly need a doctor. And if you throw a PA or nurse practitioner in there, you really, really, really don't need a doctor. So this doctor-centric thing and these little concierge practices are very doctor-centric. And that's just not scalable to a whole society. Not that I have opinions on anything.
So one, I loved your approach. Obviously, you went from the people side, and then to the whole healthcare side. My question for you is, and my father was a physician, I'm not, and he said for the rest of your life you're going to deal with M deity, and so, which is exactly what you've been talking about. And you talked about the HIV
Right person.
You talked about the HIV nurse whispering in the ear to a physician, which
Right.
words stunned me. The mental health counselor overseeing these things and whispering in the ear of the physician, which is another area I focused on. So let me ask you, culturally, do you?
Can I just give you a statistic on the mental health thing? Our psychiatrists now support 3 times the psychiatric people they used to. When they were doing it all by themselves, these are physicians, and when they're doing it all by themselves, 1/3 the number of people that they now support because they do it through the generalist, just like the HIV person. Keep going.
As you looked at it from a cultural perspective, obviously you have the Alaskan natives and that culture. You have Alaska and its culture. Do you think that the culture was able to attract the appropriate physicians? Were there physicians that didn't work in your system and you had to say goodbye? What kind of things did you see around that?
You're on mute, April.
Sorry, I wanted to unmute and get ahead of Deb to answer this. I think there's this, so early on when we had this woefully underfunded, disorganized system and our statistics were like everything low, you wanted to be high. Everyone said, oh, you can't possibly do that with that population. Look at all that, never. Now they look that Alaskan Native people have done it and they say, oh, but it's because you have this beautiful culture and, isn't it amazing? You have all these perfect parts that make it all work. And I think all of that is just baloney. So yes, we do absolutely ground what we do in the culture of our community. And the parts of that culture that matter to us are things like, we didn't share our values slide, but family is the heart of the Native community. I have gone to healthcare systems in the lower 48 and all over the world, and I can say family is the heart of the community. And is that a Native culture? Absolutely. Does that ring true to you? Absolutely. I don't think there's anything magic about the idea that for Alaska Native people, relationships matter, and that this idea of story, that we all have a story behind our eyes, and that is the journey that we are on, and all of those experiences influence how we enter relationships today. And if we can be in good relationship now, that we can be part of somebody's story walking forward. There are times when the words are a little bit odd. So we were working with a system in Canada, and they had a connotation to the word story that meant fiction, whereas for us, story means your life story. So sometimes we have to figure out the right words to use, but the heart of it, the value of culture and family, of valuing ourselves and our dignity, having pride in who we are, feeling like we have agency in our life, that life isn't doing to us, but we are doing to life, having control of. All of those things that are, you can use any kind of words you want, but I think that they're really human.
When I started doing speaking 20 years ago, people come up to me afterwards and say, Doug, you work in the most hopeless place in the U.S., maybe the planet. Why don't you come work for us instead of spitting in the wind? And now that we are wildly successful, people come up and say, well, it's because you have all these special advantages and all the wonderful Alaska Native people and culture and whatever. My middle finger gets really itchy. But what I say that's more politically correct is Alaska Native people have taken the lemons they were given and made some damn good lemonade, and shame on you, because you have better lemonades than they did when they started. Shame on you for not making even better lemonade out of your lemons.
So, question. Well, first of all, thank you for this. This is great. I actually have a familial connection. In fact, you can Google on my aunt, Caroline Lewis, and Native Alaskans. See what you get. My question for you is, and this is also, I think it addresses exactly what you said about, is it something that you're doing or is it the culture? Is there are two outcomes variables I've not heard you mention, which are the two that are most important to demographers, which are life expectancy and infant mortality. So my first question, number one, do you measure those? Number two, how do they compare to the rest of Alaska that is not using your program?
You want to take that one, Doug?
It's good that you said are most important to demographers, because I don't know that they're the most important to humans or the community that whose money we have and on whom we work for. I don't know that they would identify those as the outcomes that they most care about. On the other hand, length of life for Alaska Native people has exploded upwards. I mean, it was, not just a couple, 3 decades ago, it was like 45 or 50. Now it's like 78. And we're within, 2-3 years of other races when it used to be this massive, massive gap. And then the whole infant mortality, maternal mortality, and all that kind of stuff. Because we have relatively small numbers, it doesn't take very many deaths. So the numbers kind of bounce up and down a lot because our N sizes relative to tens of millions of people or whatever is relatively small. But yeah, dramatically better on length of life, somewhat better on the other indicators, especially around child, infant, or maternal mortality. But you know what? We've got 75 health outcomes, HEDIS benchmarks, and all that kind of stuff that have a lot to do with a lot of other dimensions of life that are more directly applicable to how people's life is a year from now than a year ago, than those very, very esoteric measures created by epidemiologists. And I'll tell you, I personally care a lot more about the quality of my life than the length of my life. And 98% of humans I encounter care a lot more about the quality of life than the length of life. Although I will tell you, the improvement in Alaska Native length of life has skyrocketed upwards. But I don't know that we can take most credit for that. That has a lot to do with clean water and housing and sanitation and lots of things that changed in society that weren't directly attributable to us.
I will also just add to what Doug's saying, that I think what we've tried to balance are those big long-term measures with things that we can empower teams, addiction treatment teams or primary care teams, to make meaningful movement on right now. And so that people in their lives can identify, I mean, one of the factors of resiliency is to be able to identify a goal and value your own movement towards that goal, right? And so we're measuring incremental change that gets to big change. And people ask us, like, how did you change culture of healthcare? And my answer is, it was really hard for the people who worked in the system, but we did it, right? And we continue to work at doing that. It's way, way, way harder to change a community's orientation to an institution. That's happening generationally. And so I think that the outcome of this, everybody has behavioral health, primary care is something different, whole person wellness, kids growing up with that reality. We're going to see that in generations to come. And Daryl sort of said the time horizons we think on, when I think about what my work, how I do my work well, how I value what I do as a CEO, I think about being a good ancestor. How do the steps we're taking today open a path for generations to come? And how can I be a good ancestor to those future generations? And I think we're doing that.
So I have a question. And this, no, because I've seen you raise your hand like over and over again. I'm going to ask you for your advice. How do you think about this kind of like de novo? You know what I mean? If you're starting this up from scratch, when you have so much working against you, you have culture that's not this. You have, this is all kind of a new idea. You have the consolidated entities who are buying up everybody. If you just were going to give one piece of advice for how to think about starting this, when, you know, we all know also culture change takes a really long time. So how do you attract somebody when you don't have 5 years to get you to say, okay, well, this is going to be great in 5 years? Do you have any advice?
I'll share mine, and Doug might have different advice. But to me, when you're thinking about, so there's a couple ways to think about change. A lot of people talk about change as being tinkering around the edges improvement. What we did was whole system redesign, walking away from the medical model and building something new. And for me, when we did that, what was important is to land the philosophy and the why in a really, really strong way, to know what you're seeking to do and to be steadfast in doing that. And how you do it, you're going to have to try and learn, but to know that's what you're going to do. And somebody said that the providers that you know that are doing this well, and I can think of one in Alaska doing this well that just is private pay, right? They just don't do insurance because there's so many drivers against doing the right thing. And I don't buy that you have to do that. So, you know, for example, when I was leading behavioral health and we were thinking about redesigning what access looks like to addiction treatment, for example, as we are redesigning, it is so hard in U.S. healthcare not to be completely driven by regulation and Medicaid plan and what insurance will pay and what Medicare will pay and kind of all of these things. And all of a sudden, all you're doing is checking the box for all of those payers, that we had to intentionally remind ourselves that we were going to do this by banking all of our assets in building relationship, real human relationship amongst provider teams and between provider teams and families. And if we could really walk with them in their journey, then we could get to wellness. And so I say as a leader, there is a bunch of laws and regulations and pressures up here, but I'm going to hold them up here and allow for the space for the creativity to do the right thing to happen. And the joke is, that means if the right intervention is to build a canoe, then I'm going to go and tell Medicare and Medicaid and insurers how that fits into their model of how they should pay us, because it counts. And when I say build a canoe, I actually literally mean that the right thing to do might be to go build a canoe. And so that kind of canoe idea, like what should we do versus what are those pressures? You have to just acknowledge them, and then at the high end, figure out the finances to run the business, follow all the laws, but not let that be the drivers, that the day-to-day interactions that provider teams have can just be doing the right thing in relationship with families in front of them.
Totally agree with April, and I would just add from a financial management perspective, a lot of people refer to us as wellness and prevention and population health and public health, which is all true. But financially, the big seller for doing what we do is the ROI on chronic disease management. Mm-hmm. So the short term, I mean, within 18 to 24 months of a full institution of a system like ours, you can, I mean, look at that data we gave you on the second slide. The amount of cost spent on people living with chronic conditions plummets, because we're just way more effective at influencing people to do the things we know that work to help keep you out of the hospital and living independently. So there is a big ROI, I mean, and not long, 18, 24 month, big ROI on the most influenceable chronic disease management conditions. And then the rest of it follows from there. And eventually you get to all the other stuff that helps just make for healthier lives and healthier families and all of that other wonderfully good stuff. But if you need to make a financial argument with the people that have the money, so, if I were dictator of the world, I'd start with people who have the money and get them to fund something different than they currently fund, which is why I believe you have this guy named Daryl who's a bit obsessed with employers because they have a lot of the money that pays for healthcare. So there, Daryl, did we bring it full circle in the end?
Yeah.
Hey, by the way, you mentioned Caroline Lewis. So actually, I think I know her as Carrie Lewis. Passed away a couple years ago. Is that right? Who mentioned that? Their relative.
As you would say, my auntie.
Your auntie, yeah.
Yeah, Carrie Lewis, who died like in 2020, right?
The end of 2020, right?
Yeah. I go to I'm very active. I'm on the board of the Unitarian Universalist Fellowship in town, where she was a member and where her service was virtually held in late fall of 2020.
Oh,
Fabulous person.
So I really appreciate how you put each person's health into context of their life circumstance and taking all of that into account. What I'm wondering is how you strive to improve their health in situations where the circumstance that they're in are beyond what you can address. So housing instability, food insecurity, those kinds of things. Thanks.
Well, I think in part we don't allow ourselves to think that those drivers of wellness are outside of what healthcare should be, right? I mean, if somebody comes to you, so if you're a primary care provider and you've got somebody coming in and you know that their diabetes control, that's what you want to work on, and they walk in and tell you that what's most important to them right now is that they're worried about getting evicted because they lost their job or they've got a teenager who's run away. We got to stop. We got to stop thinking about whatever measure we think matters most and understand what that family needs in that moment. And we have to reorient our delivery of services in that day, in that moment, right then, to be directed by what their true needs are. And we have to have a network of providers in the community, of partners in the community. We have a medical social worker who can be pulled in. We have a behaviorist who can be pulled in. And we're going to talk with that family right then about that. And there's some tension between how much of that you can do really in primary care versus what needs to be other types of services. So we have an intensive case management. So primary care has, so you had said 800 is your goal. I think that's a great goal. We're currently sitting at, what is it, 1,100, Doug, panel to primary care team ratio. But there are folks where that ratio is not going to work for them. And so intensive case managers who do community-based work have a ratio of like 1 to 18. And they have a length of clinical treatment of about 18 months. And we think that actually might be too short. And the number of touches per week that they're having with a person who is experiencing homelessness, who has some real life difficulty, is like 7 or 8 per week is how many touches per week they're having. So we've got to figure out what is going to be the primary intervention for that person and how do we modify our healthcare delivery for niche populations.
April, why don't you say a little bit about how we got payment for that using the federal waiver process with the state?
Well, I'm a really big fan of influencing how we're paid. I spent a lot of the last 10 years focused on that. And as our state designed its 1115 waiver, I was on the benefits design team. I was on the panel that selected our ASO to administer that waiver and to think about redesigning how our Medicaid system can be paid. And Alaska is not a super progressive state. In fact, our governor's vetoes came out while we were in this Zoom. So Doug and I got a little distracted for a minute because it's pretty terrifying. But we fight really, really hard to think about differently how we can be paid and reimbursed. And we Native people, April Kyle, have a really loud voice sometimes about what those payment models should be.
This ICM model, intensive case management model, is transformative for a whole section of society who are the least capable of independent life. And we get paid. We're not getting rich off of it. In fact, April, I'm not sure we quite break even or we're close to break even. We're not making a profit or margin off of this, but we're saving ourselves and the system a ton of money and massively improving these individuals' lives. And because April Kyle sat in every meeting at the state level to influence policy around this wonderful thing where you can do federal waivers, the state can do waivers through Medicaid for the federal government.
And behavioral health, Yeah, behavioral
go
health
ahead.
crisis is next, and behavioral health crisis is going to push us to think about where those savings really are, and the savings not only in the slide we had around higher acuity, more expensive healthcare use, but also our public safety and our jail system, and just this horrible, I mean, you guys all know the story, as we reduced institutionalization of people who experience a behavioral health need, we just replaced it with putting people in jail. So how can we really think differently about where we put our dollars to get to wellness? And there's some movement, there's some water movement in that direction that we want to be part of.
Awesome. We are out of time. I'm going to wrap this up with a story, because last week when I was in Alaska, this year we did our aspirational healthcare conference in tandem with the Nuka conference. That's where Vidar came up, and we're planning a conference next year focused on bringing CEOs, business leaders to Alaska on their campus to learn how they can influence what they're purchasing, CQI. So this last week for me was to go visit with a bunch of wilderness adventure groups to talk about what can we plan to draw CEOs up to Alaska next week. Well, wilderness or Alaskan ATV Adventures is one that I met with, Michaela, who just happened to tell me, this is not connected me with them at all. She's Alaska Native. Her husband is not. It was so cool to hear her tell the story of her living and growing up in the Nuka system compared to the stuff her husband has to deal with outside of the Nuka system. I was like, wow, what a stamp of contrast, black and white, for somebody that they didn't introduce me to. I just went out and saw her. She just happened to tell me how different those two were. So I'm going to put a stamp on that with that little story. Please come up next year and participate and bring as many CEOs as you can, because we've got to get the buyer of healthcare to see they're buying a bad product at a bad price. And with that, thank you, Vidar, for this opportunity. Thank you for everybody. Let's give them a hand of applause.